Good evening, everyone. I'm so excited that you're here today. We've got some amazing guests today, but first I want to say thank you to my MC Media, Olivia, Chad, Carolyn, and Rohan for pulling this webinar together. And I also want to give a shout out to Healthcare Initiative Foundation, who works tirelessly in our communities to improve the health and wellness and outcomes of our Montgomery County residents. Our distinguished panelists today are Dr. Stephen Thomas. He's the director of the Center for Health Equity from the University of Maryland. We have Dr. Brian Smedley, who is the Equity Scholar and Senior Fellow, the Urban Institute. And then we also have Usha Lee McFarling, who's the National Science Correspondent and STAT. So today we're going to get started with, I just want them to just give just a brief synopsis of who they are. We all have their bio, so you can go and read their entire bio. So I'd like to start off with Usha. Can you just tell us a little bit about you, please?
Sure thing. And yeah, thanks again for having me be part of this. I'm really thrilled to be here. I am a science and medical writer. I work for Stat News, which is part of the Boston Globe. And I cover, for 2 years now, I've covered the intersection of race with science and medicine. And so the number one topic for me really is health disparities and what's causing them.
Wonderful. Okay, Dr. Brian Smedley, would you like to give us a brief synopsis?
Sure. Thank you as well for convening this group. This is a really important conversation. I'm Brian Smedley. I'm an equity scholar and senior fellow at the Urban Institute, which is a think tank here in Washington, D.C. I've been studying health care disparities, racial and ethnic disparities in access to care, quality of care, and outcomes of care. But I've also studied what we call societal and political determinants of health, conditions in communities and neighborhoods that make people sick or healthy in the first place. So structural racism and other institutional forms of racism are complicit behind all of these kinds of inequities. So that's been my career's focus. Thanks for having me.
Dr. Stephen Thomas.
Thank you so much for this opportunity. And these Barber poles behind me are part of my story. And at the appropriate time, I'd like to take you as close as possible into the community. And maybe that could help us set the stage for the conversation we're going to have tonight. Are you ready to go into the community?
We're ready.
The 25th anniversary of the African American Cultural Festival in Towson in Baltimore County. And I'll never forget a grandmother. She was eligible to get vaccinated in the very first wave, but here she was not vaccinated.
Yeah, I just didn't go nowhere to do it.
She says, I'm not going to tell my children I got vaccinated.
They're not going to get it.
And I'm saying, why is that? I remember when I got vaccinated. Tell me when it's over.
It's over.
It's over. I took videos and posted it on Facebook. A celebration.
It was easy. I thought it was going to hurt, but it didn't.
She got vaccinated. We heard her anxiety about not telling her family. But we also saw her frustration with a system that almost had her entering the wrong information for her next shot. The whole strategy is to bring the care to the community, to bring the care to settings where people already have trust, and to recognize that those may be unusual settings. And we were able to make arrangements for our Center for Health Equity where people came in to get the literature and, hey, a free haircut. We created that sacred space at a festival. And while they're sitting down relaxing, they're looking right across at the clinic where people are getting vaccinated, literally 15 feet away.
The whole family's are covered. Oh, great.
Who could have imagined we could turn barbershops and beauty salons into trusted information centers for COVID and beyond?
I was comfortable with coming here. I actually feel comfortable here than I would at a normal clinic.
Community engaged research can also serve the community. It's a place where you have trustworthy messengers.
Good afternoon.
I don't think that I can fully communicate what it was like to have the White House briefing come on TV.
In the spirit of meeting people where they are, we'll also be working with the Black Coalition Against COVID and other organizations to launch a new initiative called Shots at the Shop.
I couldn't believe I was hearing
Beauty
it.
shops are hubs of activity and information in Black and brown communities in particular, but in many communities across the nation. Local barbers, stylists, they become key advocates for vaccinations in their communities, offering information to customers, booking appointments for them, even using their own businesses as vaccination sites.
After our first vaccine clinic at a barbershop beauty salon, we get a call from the White House. You think you could scale this? And the rest is history.
To the first 25 people to get vaccinated.
We have over 1,000 barbershops and beauty salons across the country now part of the network. We can connect any barbershop or beauty salon in the country with a clinical partner to deliver COVID vaccines and ideally other health services. That's happening right now. And that's why, being here at the University of Maryland and our geographic advantage, so the solutions we come up with here can be applied across the country. If the hospitals can deliver a life-saving vaccine in a barbershop and a beauty salon, well, why can't they deliver the flu shot there? Why can't we do the diabetes test there? Why can't we do all the other non-invasive screenings that don't require you to be tethered to a hospital right there in the neighborhood? I think this is the game changer. And what I really like is that Maryland is leading the way.
On our shows, let's snap for that grandmother who, defied her family's pressure, and got herself vaccinated. And Brian, in many ways, it's a testament to the work you set in motion way back when that IOM report. We know the data. It's time to take action. And the pandemic, with all of its unfortunate suffering, did give us an opportunity to see maybe some silver linings that we should continue to support.
Oh my gosh, Dr. Thomas, that was absolutely wonderful. And I can totally relate to that because I have done so much work in our community, in our African-American, African diaspora and Caribbean community, just because there was not enough information to debunk the disinformation about getting COVID outreach to our community. So what you have done is absolutely wonderful. And I just want to give you kudos for that and for showing us that, because that really is really showing people what really works. And like you said, why can't we be in the communities doing the work, right?
There you go.
And that's what you're doing. So thank you so much. Like, how did you just get all these people together? I mean, did you go door to door? Did you go directly to the hair salons and the barbershops? Do you have community partners?
Well, and Dr. Smedley knows this, that community-based work is long and hard, and some of it's behind the scenes. And so this work has actually been going on for the past 20 years. In many ways, it took a pandemic for it to be lifted up as something of value and worthy of investment. But Brian knows, and I'm sure you do, Kim, but some of my white friends in the audience out there may not know that no self-respecting Black barber would ever say, I'll get you out in 10 minutes. You're going to be there all day, no matter how much hair you have.
Exactly.
It's a community gathering place. It's and our events feel like you're coming to a festival, not that you're coming to a hospital. So we treated people with dignity and respect. And the last thing I'll say as we open this up is this. When the healthcare professionals came in and gave the shot, when people finally opened up and rolled up their sleeves, the health professionals were so happy. You could see it in their face. And people came to the event hesitant, and many left hesitant, but vaccinated.
Yeah.
So the whole point is that it was treating people with dignity and respect and meeting them where they were, not chastising them, not scolding them,
Right.
that enabled us to be successful. So if the health professionals are out there listening, don't abandon us. And don't abandon us.
Thank you so much. So Dr. Smedley, let's talk about you and what you've done in the community and how this pertains to making sure that the information is being disseminated, and so that we're making sure that these inequities are being dealt with. So please tell us your story.
Let me start by saying that what Dr. Thomas just showed you is resiliency and strength in communities that are too often stigmatized, too often assumed to be weak in the face of adversity. Communities came together in the face of COVID. Those that did not, I think, were at greater risk. I think the United States at large suffered from deep social division, which contributed to us having among the highest mortality in the world due to COVID for the early parts of the pandemic. The distrust, the social division, the social acceptance of racist, xenophobic, anti-Semitic language, misogynist language, this all contributes to a backdrop that makes it more difficult for societies to fight COVID, because these are times when we have to come together. So I wanted to just start by saying to Dr. Thomas that I've long admired his work, and this is resiliency. This is communities that come together, that show collective efficacy. And, you know, Dr. Thomas and his team are well aware that that resiliency, that strength is there. And so collective efficacy, I hope, is one of the lessons we learned from COVID, and relates to the issue of equity, because for too long, communities of color have been divided geographically, financially, linguistically, et cetera. And so to the extent that we can find opportunities to bring communities together in the face of not just a public health pandemic, but the ongoing public health crises that we face, violence in our schools and communities, chronic disease, all the other challenges. And so that's why the model that Dr. Thomas has harnessed is so important and applicable, not just for vaccination, as his other research has shown, but to the range of other issues that require communities to come together.
Thank you for sharing those. So Dr. Thomas, would you like to add to that?
Well, you know, this is such a robust conversation, and you described the misinformation that was in our communities even before COVID. The issues around trust are now front and center. And that's why I think it's so important to have coverage of the examples, as Dr. Smedley said, of when the communities do something positive, when they actually come together. Whole lot of stories about misinformation, whole lot of stories about distrust. But here was an example of where they actually came together. But we had to produce that. I wish we would have had the mainstream press there. But we have friends like we have at STAT that may well shine a light on the ways in which our communities are going to take charge of their own health, and that the pandemic was a wake-up call to address the other underlying concerns. You know what they said to me? They said, "Hey, Dr. T," that's my nickname. When they give you a nickname, you know you're all right. Are they just going to give us the jab and leave us with the cancer? Are they just going to give us the jab and leave us with the diabetes? I told them I was committed to make sure that did not happen. And Dr. Smedley, you know that can't happen if the positive things in our community are hidden, but all the negative is in the front page headline. So I can't wait to hear how our content expert from the press will help us navigate the new journalism that's out there.
Well, that's a good segue into a question for Usha. So I'm so glad that you said that, Dr. Smedley. So I was just going to ask you, while COVID-19 brought, health disparities to light, what can journalists do to improve the coverage, right? And to keep the momentum and the spotlight?
Yeah, no, it's a great question. I know for me personally, the pandemic was what brought me to this work. We saw those just striking numbers of how many more Black and Hispanic and Indigenous people were being killed by the virus than other populations. And when the pandemic ended that first time, I think in April 21, when the vaccines came out, and we all said, well, okay, what are we going to cover now that the pandemic's over? And I just thought, well, what's causing these disparities? Like, what is underneath it? Like, why are we here right now? This, fabulous medical system, wealthy country. Like, how did we end up like this? So I've been on a journey to kind of understand some of those questions and reasons why. And we talked about in planning for this, does the press have a responsibility to cover health disparities? And I definitely think they do. In my recent reporting, there's been these new analyses. So just in the past 20 years, we've lost, there's been 60 million years of lives lost because, Black people are dying earlier and, dying way too soon. It's 1.63 million lives. That's empty chairs at dinner tables. And it's not, due to homicide, which is what a lot of people think. It's cancer, it's diabetes, it's all the things that kill. And also infant mortality, which is really, that's robbing a whole lifespan. And David Williams, who's an, very esteemed health equity researcher, says this is like as if a jumbo jet fully loaded fell out of the sky every day. That many people died every single day. And there, if that happened, there'd be task forces, there'd be crises, and I'll add there'd be wall-to-wall media coverage, of course, and yet there's nothing. There's like no response. No one, like it really is a national crisis and no one's doing anything. And so I do think that the media has been part of the problem for not really poking at this and probing it and saying that it's unacceptable.
Thank you so much, Usha. You're absolutely right. Thank you so much for sharing that. Dr. Thomas, wow. Because of all these inequities, the social determinants of health, I've really noticed that there has just been a big uptick in the mental health crisis within our communities. And so I was just wondering, you've done such a wonderful job with creating, this opportunity to go into barbershops and go into the communities. Do you see an opportunity to create something like a mental health piece like that for the communities?
There are some very promising practices out there. And I think this goes right to Ursa's point about shining the spotlight. And I'm wondering if one of the ways, after we've seen all this data and science, I'm just wondering if the personal stories are what might help build a little more empathy. The pandemic really showed a certain coarseness, talking about certain populations, the elderly, at the doorstep of God kind of thing, that we let people be less than simply by age. It exposed some things that have to be brought to the forefront. And it's in that context that the press is so important, because things are so fragmented. And it's in that context also that what we're doing here tonight, I think that many of the people we've engaged, Brian, out there in the community, yeah, they knew about Zoom. Yeah, they've been online. They know YouTube. But webinars, conferences where they're speaking to people all over the world, that's a game changer for them. So we need folks to do these town halls. The government, Montgomery County excluded because they're doing it here tonight, many of those infrastructure components that brought us the webinars are now in retreat. Who's convening us? And so the press and local county governments, hyper-local, Ursa, that was the lesson coming out of the pandemic. We got to get hyper-local and tell our stories.
Absolutely. Dr. Smedley, would you like to add anything?
Sure. Yeah, I agree with everything that Stephen said. And but just to add to this heavy responsibility on journalists, I sure wish we could have told a better story during COVID about the root causes of the inequities that were so widely reported in the press. So if people were paying attention, they knew that people of color were more likely to get sick, more likely to have complications due to the infection, had higher mortality. But a lot of news outlets left the story there, which unfortunately reinforced broad cultural narratives that there might be something genetic or biological about race that might explain these differences. Are Black people more vulnerable genetically, biologically? That can't be the narrative. We know that that's not true. Geneticists will tell you that, physicians will tell you that. And so what I appreciated is the kind of reporting that speaks to why we have such a higher burden of chronic disease in communities of color, particularly low-income communities of color. Yes, these were folks who were on the front lines, often in jobs that put them at risk for infection. True, disproportionately. These were folk who could not afford to miss work if they got sick, who had relatives and family to worry about if they got sick. But the root causes of these inequities that we saw, differences in rates of chronic disease, diabetes, heart disease, that's what put people at risk. And of course, that virus didn't put that at risk. What put people at risk for those chronic diseases is racism. That limits socioeconomic mobility for people of color. That limits access to health care for people of color. That limits, in so many ways, the resources that we all need for opportunities for good health. That's true, unfortunately, here in Montgomery County, just as it is nationwide. In Montgomery County, we're a wealthy county, but despite that wealth, there are deep inequities, economic, linguistic, based on nativity and immigration status. And of course, we know that many of our community members, our neighbors who might not be here with documentation or who are recent immigrants who've arrived here legally are not eligible in many cases for federal programs such as Medicaid that are important to ensure access to basic health care. So we have the basic problem of racism at the core of that higher risk for communities of color for poor outcomes during COVID. Usha and her colleagues told wonderful evidence-based stories about that higher burden among communities of color. And so I really encourage journalists to look at what Usha and her colleagues publish, and others who are doing good work to really talk about the true root causes of racial and ethnic health inequities rooted in racism, not in genetics.
Dr. Smedley, you want to cause trouble. Look at you using the R word.
Well,
Racism.
that's our job, Stephen.
I'm just glad we're not in certain states where somehow that could get a ban.
Exactly.
And that's
right.
my point,
Exactly.
Ursa. When you see what's going on, Brian and I both have a little, gray. This didn't even exist before COVID, but it's a story about the arc that we're in. And so the weaponization of our language, the weaponization of even health equity, the word equity and inclusion. Ursa, what do we need to do? You're talking to the choir, but each of us have a part to sing, and we don't practice enough when we come up against the pushback. How might we do a better job communicating with our journalist partners to get the story right?
Yeah, that's a great question. I was thinking about this, like, why isn't there more coverage of health disparities? And I really think it's due to our whole cultural discomfort with even talking about race or dealing with it. We're such a segregated country because, okay, health disparities is a difficult, complex topic. I mean, Brian edited an 800-page report about it, but science journalists and medical, we cover difficult things. We just covered a novel coronavirus, right? We cover astrophysics. We can cover hard things, but somehow when it comes to race, we're like, oh my God, like, look at our shoes. We're so uncomfortable. And so I spent a lot of my time calling out the lack of diversity within medicine. I just had a story yesterday. I don't know if you know, nursing is 82% white. It's a real problem, especially in specialty nurses and nurse professors, and it's really there's a huge amount of racism within the field, and nurses experiencing racism, not just from patients, but from their colleagues. And it just really opened my eyes. It just, I don't know, very frustrating that this is all happening, but I should be open and honest about journalism having much of the same problem. I was looking at the numbers. Journalism is 76% white, which surprised me. I thought it would be higher. But if you look at my field, science writing, specialty reporting, where you often are senior or you've had a lot of years, or the top editors who are making the decisions of what goes into the newspaper or on the website or into the documentary, I'd say that's closer to 90% white. So I think we have these huge blind spots where we're not talking to people that are not like ourselves. We're not covering different communities. There has been many Black journalists who have spoken up and said they were told they couldn't cover Black communities as Black reporters because they'd be biased.
Wow. It's probably a little bit of a slow internet on her end, but it's interesting hearing her take us under the hood of the journalist room. It's sobering.
It is very sobering. And so how do we improve that though? How do we get around that? How do we make it so that, more voices are heard?
You know what we can do? When we find journalists, when we find publications that speak to us, that speak to the narrative as Dr. Smedley has eloquently described, what we should get a subscription. We're going to have to let our values follow our dollars. Yeah. And so when we're in my colleagues, my students, to introduce them to STAT, to make sure that your stories are in our curriculum, that's what we have to do. because the business models are not going to change overnight. And it looks like you're fully back, Ursa.
Yeah, I apologize. Did I get cut off because I said the R word?
No, you're not in Florida.
Yeah, you're not in Florida.
You're in
so.
Montgomery County, Maryland.
That's right. So please finish what you were saying.
Oh, well, the end of it was just, yes, when you are doing interviews, bring up racism. I think for so long because of our discomfort, we've used terms like social determinants of health, and these are important concepts, but really, it's people live in poor neighborhoods because of redlining, which was racist. And then they live next to the smelter and then they get asthma. So it's racism. It's not dancing around these jargony topics because we don't want to say that word. And reporters need to be able to handle it. And we need to speak about racism directly. That's the number one thing I've learned in my coverage.
Wow, people are signing up for subscriptions right now.
They're signing up. Well, one of the things and I just wanted to mention it because I was having a conversation the other day, is like people are actually afraid, and I think we kind of hit this a little bit, of saying Black and brown. Now they want to say underserved people because they don't want to use that terminology, because they don't want to really say that they're going to be responsible for helping one community as opposed to another community. So what are the terms that you should use? I heard you say people should talk more about race, but that's not so easy for people, because people don't necessarily, depending on your community, want to talk about Black and brown people, want to talk about what's happening in these poor communities. So we with these reporters, it's up to us to try to give them the language.
Yeah, I think this is even in the 2 years I've been covering this, I've seen language evolve. I think because there is a national conversation. After I finish, I'd love to hear Brian, because he's been working on this so many more years than me. But, I think we're not using the term minorities anymore, because first of all, it's not going to be true, right?
Right.
And second of all, it's gotten this sort of categorizes people. Sometimes you see underserved or marginalized. I hear minoritized, but that's getting more too jargony for me. I do use Black and brown because that's descriptive.
Okay.
I'm using people of color less, because someone pointed out we're not purple and green, like we're really like say the colors that people are. The best is to use exactly what people are and ask what they prefer. So is someone Indigenous, or are they Lakota? Is someone, we use the term Black with a capital B because that's what Associated Press style is. But I recently interviewed actually an incredible critical care nurse from your institution, Stephen, and he asked to be called African American, which to me seemed like a much older term than his age. Okay. But that's what he wanted, and I respect that. So I think ask people the terms they want and try to use that. And we are working to constantly update our language to be fair and unprejudiced. And for instance, we're told not to use urban violence because that just is a very stigmatizing term. Yes. And so I do. That's one thing about this work. I'm like always thinking about the term and how's that going to hit and how will that sound? And does that make someone sound like less than they are as a human being? And I try to avoid that.
Right. No, absolutely. Because I just think that when you're talking to people and you're reporting, things are bad, but you also have to see the humanity in people, right? You have to see that humanity, and you have to we're all a part of this world, whether you want to live together or not. So it's just really important from my point of view is that we all have to be really respectful for one another. And there's nothing wrong with saying, I am Black, I am African American, or a white person saying that. Sometimes, you get a little weirded out because people are actually calling out a race or something. But if you don't call it out, that's when it becomes uncomfortable.
That's right, Kimberly. And, I would add it's interesting, even some of the language that is, I would argue, residual, old language is instructive. You use the term underserved. The Biden administration still uses that term as if services or a lack of services were the problem. That's clearly not the case.
Right.
So even when folks use terms like underserved, I take that as an opportunity to have a conversation and to talk about what would it take for communities to have equal opportunity. Services are important, clearly, but services will not undo 400 years of structural racism. So, so I find that even as this language evolves, terms that are still in use, again, I'm not at all critical of the, I don't mean to be critical of the Biden administration in the sense that their equity agenda is far more ambitious than any prior administration, and I applaud them for that. But it is surprising to see the term underserved in the narrative that they're using, because services clearly, or lack of it, are not the problem.
Yeah, as I'm hearing you and recognizing how slow the wheels of government move. I mean, we have the National Institutes of Minority Health and Health Disparities. Some of this is tied up in the legislation, but you're absolutely right in terms of reimagining or how the language keeps us locked in a box. So it's time to kind of reimagine, maybe even redefine some things. And so we've been talking about those social determinants in terms like race and what do we, Latinx or all. How about reimagining what we mean when we say love? Because at the end of the day, that's what was missing out there.
Yeah.
Because if you don't care about me, my vulnerability when I'm sick. So let's redefine love, leaving others very encouraged. How about that? How about giving some love?
I love that.
We need a lot more acts of kindness in the grocery store.
Absolutely.
In the parking lot. I mean, people are on a razor's edge.
Yes.
And if we don't figure out how to come back together and have conversations, even when we disagree, we don't have to be disagreeable.
Right.
We got a bigger problem. So that's why I'm hanging out in the barbershops. That's where all the conversation, you can say nothing wrong in the shops.
And you want to know something? Just seeing somebody in the grocery store or walking down the street and just a hi and a smile can just brighten somebody's day. And when I'm talking about my teen mental health and It Takes a Village, people are walking around and they are just in la la land. And if a kid is having a bad day and somebody in the cafeteria notices that this kid is having a bad day and they say a smile and give them an extra piece of cheese on their omelet, that's an act of kindness because you're recognizing and you're honoring that person's humanity piece. So you're absolutely right. I just think that we have to do such a better job, of making it a point to be kind and to talk to people. And you'd be surprised because sometimes you look at people and you're like, oh my God, I'm not going to sit next to him. He looks like a whatever it's called. And then you're on a plane and you're sitting next to a person and you realize that this person is accompanying their son, who is a paraplegic, to a soccer game because he can no longer play, but his dad is taking him there and you're having a conversation. And for me, I was looking at him as like, oh my gosh, I don't want to sit next to this person. So you never judge a book by its cover.
That's right.
I tell that story all the time because talking about what love that father had for his son.
That's right.
And he was telling the story so that, it just really drew me in. So I totally agree with you, Dr. Thomason. Love is the way to go. I'm really in for love. So anybody else want to talk about how love can just improve all of our lives?
We've just been through a trauma. We've all been traumatized with the 3 years of the pandemic. And so you mentioned mental health, and I didn't want to leave that. We just reframe it. The stigma, it's like the skunk in the room.
Yeah.
We don't come in with mental health.
Yeah.
We can talk about it through issues of stress. And in our communities, everybody knows about stress.
Well, it's generational trauma.
And so that way you can back your way into the trauma and into the mental health in a non-threatening way. And that's what we need to figure out how to do. Help people heal themselves.
Absolutely. Absolutely. So, Usha, I've got a question for you. Mm-hmm. So what, if anything, are newsrooms doing to diversify their journalism staff?
Well, they're recruiting at, we have NABJ, NAJA, NAHJ. We have a lot of AAJA. We have all our organizations, so they go and recruit. But we're trying to get, start interns and train them to rise up. To me, it's going far too slowly. But the last topic, I wanted to add something. We're talking about the language we use. And I think we need to think, and someone mentioned telling personal stories and the importance of that. And I think that's really, really important. Like, that's one reason that video was so powerful. There were some personalities in there. There was a lot of joy. So often as medical journalists, we have this trope of the patient's story, right? So you're writing whatever basic story, pancreatic cancer rates on the rise in this county, and you want to get a patient. And I think when we're covering health equity, many of the patients are very vulnerable, and many, it's so important to tell those stories, but as a reporter, it's also really important to make sure you are not harming a person further. Even though you have these lofty goals and you're trying to do good, you have to make sure that that individual or those individuals you speak to, and a lot of people aren't that sophisticated with the media. So you have to really make clear, thank you for sharing this story. It's so powerful. People are going to learn a lot, but they need to be clear that this is going to be all over the internet. And it can't come back, and so I don't know that all reporters realize that. They just assume everyone knows, well, I've got my notebook open and I'm taking notes, so they must know. But I think people start talking and share a lot. And so I'm extra careful. Like, I go back and I, like with this nurse, I was talking, how do you want to be identified? Can I share this? You told this story, and I just want to make sure you're comfortable, because this is going to be in my report and it kind of becomes permanent. And I think we as journalists have to reframe like how we even think about doing this reporting when people could be harmed by it. And I think that's really, really foreign concept to a lot of journalists. Who just assume this is a transaction and they're going to get something out of it, and I am, but a lot of people aren't. But they are willing to tell their story because they want to help others.
Yeah.
They don't want other people to have the same like medical issues. I did a story recently on Black men and women in their 60s, 70s, 80s who are signing up to donate their brains to science because an amazing Black cognitive neuropsychologist is running the program. And she spent like 5 years talking at senior centers, building up trust before she even asked the first person.
Yeah.
And one of the participants told me, I just, maybe they'll learn something. Maybe my kids or my grandkids won't get Alzheimer's at a higher rate, because I want to help. And they wanted to talk to me because they want that message to get out, that it's okay to be part of science, and you're not necessarily going to get experimented on in some evil way, which has happened in the past.
You're exactly right. And that's actually what happened during COVID. We really had to go out and say, hey, listen, this is not the Tuskegee Institute, right? These are Black scientists. These are people, of, here we say, go again, of color, who are actually researching the scientists, and they're not going to let anything bad happen to, Black communities anymore. So you're absolutely right.
Here you bring up the, the kind of the gold standard of why we distrust. And so I'll use that as an opportunity during the pandemic, because it was used by some policy officials to say, see, this is why Black people aren't getting the vaccine.
Exactly.
Not a problem with our distribution. It's not a problem with our ranking system. It's not a problem with our putting a life-saving vaccine at the end of the internet and not ensuring everyone had access. And so there's also harm in what our people don't hear. Yes, they can be caricatured and minimized in a story, but they also can be uplifted. And it's in that context that now I'm speaking to your peers, your colleagues, to say a lot of the human interest stories were behind a paywall. And they would say, well, we put the COVID stories in front of the paywall, and that was the epidemiology, the science, and I get that. But those personal stories that could uplift, we didn't see as many of those. And Usha, again, if you can help us understand, in addition to getting a subscription to the newspapers, how we make sure that maybe through public libraries or other ways that our community can hear their own stories reflected in the news. Is there anything we should be doing differently?
I would say answer the calls when the journalists do call, because I do, honestly, I make a point. I try to always have women speak in my stories, because there are women doctors and scientists, but you wouldn't really know that. I'm reading most of the mainstream media. And of course, I always focus on, physicians who are Hispanic, Black, Indigenous, like just for different perspectives. And that's like probably my biggest tip actually to young journalists who want to start out at this. Just diversify your sources because people are out there. But I will say oftentimes, and maybe it's because this doctor works at a community clinic and doesn't have an admin and it doesn't even have time to check their email, people don't get back to me in time. And then so sometimes then you end up on deadline going back to the usual sources, which is like the head of pathology at Johns Hopkins, was a great guy, but like a white male. So do answer those calls in a timely way. And I think it's fair to check out a journalist. You can see all our work online to decide if you want to talk to us. If we seem trustworthy, you can even ask a journalist, well, what's this about? What do you want to know? What are you planning? Because I do think there's a lot of mistrust, not just of medicine and science, but of journalists because of how it's been portrayed. So that's fair game to just ask, what are you up to? What are you going to do? Can you send me some other examples of your work? It's fine to say no if you don't think they'll do a good job or a fair job. But really, I think I would want journalists to diversify their sources. I want those diverse sources to call the journalists back so the stories can reflect all those viewpoints.
I'm listening to you and I'm realizing that for the Barbers, and if we were to collect all the stories that they were interviewed in, it's quite amazing. But you are absolutely right. To make that happen, we created a group text thread. And I would usually get the call from the reporter because at the university, you know how it goes, they go to their source. They said, can you connect me with one of the Barbers? Well, I had to address the very issue you've just described. And they live on text. And it was in real time. And all of a sudden, now we were addressing the needs of the journalists. They're on deadline. But we need to put a little bit of an infrastructure in place that would help get those stories out. And for some of our folks, we gave them media training. So they weren't intimidated when the cameras started rolling.
Yes.
That's wonderful. And it also helps. And if you say like, oh, this is so-and-so from the Washington Post, a great guy, talk to him. Yes. That helps too, because oftentimes, we'll call someone and be like, who are you? Like, what are you talking about? Who are you? How'd you get my number? So having that trusted intermediary really helps. And it can slow things down. So I think sometimes, it does take, sometimes my stories take me a while because to get people to talk in an honest way. So journalists that's not always possible. Sometimes we're on a very tight turnaround, but journalists have to build that time in.
But Usha, I have to say something though, because sometimes I don't think that they're interviewing like the right people. I mean, I hate to say it, the right people, but it just seems like sometimes it's so high level that people aren't going to pay attention. If you want the real stories with real people, right? So how do you go about, well, with Dr. Thomas, he can take you to the barbershop, right? So, and meet all his people, but just, other people that have stories to share and they don't know an Usha, they don't know, reporters, but they have amazing stories to share. I mean, how do reporters, how do they get real people to talk about these things?
Well, I think that's what's great about having a diverse newsroom, because I live in Los Angeles, and the Los Angeles Times with incredible Hispanic, Asian, and Black reporters were able to report on their own communities. One reporter wrote a just heartbreaking tale about a Black reporter losing her father to COVID. A Hispanic reporter was able to write about her grandmother and how COVID just ripped through her family, nieces, nephews, uncles. And, they can tell those stories because they're living them, and that's part of it. And they know all of those people. So I think that's the best. And the other is, just as really the best health equity researchers center the community in their work, I'm learning from them and I'm trying to do it in mine. And so I need the Stevens, or the Alzheimer's researchers, Lisa Barnes, I need them to introduce me and be a mediator, and because I can't just show up, you can't just show up and expect everybody to talk to you. But you really have to make the effort.
Dr. Smedley, when we put our community in those situations and they're vulnerable, or whether it's the local language they use, I'm always sensitive to how's this reporter going to frame that. And so for us, it's important for them to realize that the barbers and stylists we work with have actually gone through formal training. They're like certified community health workers by the state of Maryland. They've just completed 17 hours of training from the CDC in diabetes prevention. And they're about to launch their program, Cut for Health, right there in Montgomery County. So you'll be hearing more about it. So it's not just, oh, here's a barber shop, or here's a barber or stylist trying to be a health professional. No, they truly are making a difference. And if we give them the tools that they need, they can actually help promote health and prevent disease.
Right. And they should be respected for that, that education, that credentialism. I mean, that's one thing, especially it's fresh in my mind because I just wrote the story about the nurses, but think about it. You've gone to school, you've got, maybe a master's in nursing, maybe even a doctorate, or you're a psychiatric mental health, nurse practitioner, and you walk. And also it's interesting because males are minority in nursing, right? So one guy from the Dominican Republic, he's like, I'm a triple minority. I'm Black, Hispanic, and male. And he's educated up, like so educated, has all of the degrees, like an alphabet after his name. And he walks in to treat someone and they're like, can you take my tray? They don't even think he's a nurse because, so these are, the issues of the disrespect. And I sometimes cringe because I see that my fellow reporters being really patronizing. And not respecting like the community knowledge and wisdom. And it just goes off the rails right away. And, when I've observed that, I'm like, I'm so sorry for, but it's about being honest, about being open. I've learned that sometimes people want to know about me, which I'm not that comfortable with. But they want to know who I am and where did I grow up and who are my parents. And that's so interesting because that has not happened to me in generally reporting on like just general, professional white people. So that's been really eye-opening too and lovely.
And, by opening up, this is what I think is so important, that you have to give some of yourself to get something back. And there's been so much extraction in our communities of the burdens of race and history. And Brian, I wondered to what extent we contribute to it some in that we give all the data. All of our data is in the public domain. But as soon as we show that there is a food desert or a concentration of chronic disease, and we put that out in our journals, well, there are other people who look at that same thing and say, I may not want to put a grocery store there. Right. The workforce there will be a burden on my healthcare because of the chronic diseases that we epidemiologists and others have put out there. So I think it's not telling the full story, but we have to put a context on it, as you did early when you were describing why were more people of color, Black and brown, more likely to get COVID, because they're more likely to have essential jobs. I don't think the sanitation worker thought his job was that essential to put him out every day, because my sanitation was collected during the entire pandemic. Our people were out there in those jobs.
Yes. We have so many heroes to thank who took care of us during this incredible period. Even collecting trash is a public health intervention.
That's right.
But you're so right. And this is where, journalists have an opportunity to frame a story. Stephen, you were referencing the efforts to bring grocery stores into food deserts. Always difficult because profit margins are slim for grocery stores and grocery chains. But we know that some policies have worked, like the Fresh Food Financing Initiative, which provides tax incentives and land use breaks and other kinds of local incentives for grocery stores to come into so-called food deserts and set up shop. Those that take advantage of these kinds of policies achieve a triple bottom line. It's a win-win-win for the community in that there are more jobs in the community at these stores, more nutritious food available for retail, and a win for the grocery stores in that they turn a profit with those kinds of tax incentives. So there are opportunities to tell stories of policies that are working that are really important, because we live in an age of deep cynicism about the potential for any policy to do any good for anybody on the left and the right.
That's right.
Well, thank you, Dr. Smedley. And we're actually coming to almost a close. Give us some community wisdom, and what can you leave to, leave our audience with something very positive?
Sure. Well, again, I appreciate this opportunity speaking to people who are informing our community, you journalists informing our community. I care a lot about this community because I live here. And so I think as we've talked about, telling positive stories about community resiliency, stories about policies that are working. The government will never toot its own horn if a policy is working well. And so we need our journalists to be telling stories about things like the child tax credit, which was enormously beneficial to low-income families during COVID and helped many families to stay afloat at tax time. So telling those stories are critically important, but also understanding the role of collective efficacy, the ability of our communities to come together to solve their own problems. Collective efficacy is the tool that will help us to survive future pandemics, including economic downturns, et cetera. Unfortunately, we suffer from deep social and economic and racial division at this time in our country. Elected officials have stoked bigotry for votes, and this has created an atmosphere where the resurgence of expressions of hatred is permissible again. I think journalists stand with all good people in decrying hate speech. And so to the extent that we can show the relationship between hate speech and collective efficacy. In other words, hate speech forms a barrier to our ability to come together to solve our challenges. Telling those stories, I think, are incredibly important, not only at a local level here in Montgomery County, but also nationally.
Usha, can you please share some wisdom for the journalists?
Sure. I will tell, any journalist listening to this that you can do this, you can take on this topic, and it's extremely rewarding. People always ask, how do you find your stories? You're telling stories no one else is. It's so fresh and new, which, it's a challenge in journalism because we need news, and people will say, well, racism's been around since 1619, so that's not news, I can't cover it. But you can always find stories, and oftentimes because this is being ignored, there are just so many stories to tell that haven't been told, new voices. I mean, I think that's the most exciting thing for me, giving voice to someone who's saying something that others haven't heard. And so I think and it's not that hard to find diverse sources. It really is not. If you're doing a story on heart disease, there's an association of Black cardiologists. If you're doing, you can Google people, you can look at their pictures on the web to determine what race they are. And I guarantee you, people from communities that have not received a lot of coverage are going to have different and interesting viewpoints to add to whatever you're writing.
Wonderful. Dr. Thomas.
Well, what an amazing conversation we've had tonight. And kind of on behalf of the University of Maryland Center for Health Equity, our motto is building bridges, building trust, building healthy communities. And in order to get to trust, you have to walk through the truth.
Yes.
And so I say to the journalists, this is no time to sanitize the discourse, okay? And so many journalists kind of discovered the legacy of the syphilis study. But then the families are saying, tell the truth. And the truth is the U.S. Public Health Service study of untreated syphilis in the Negro male. That's the name of the study. Don't denigrate the city. That's a great city and a great university. So, and then I'll simply say this, that we definitely need to leave others very encouraged. If we don't come to some way of loving one another again in all of our complexities and differences and vulnerabilities, then we're in big trouble. But tonight has given me hope that right here in Montgomery County and in the great state of Maryland, we're going to show the way for the nation.
Well, I just want to get invited to the barber shops. I'm going to come do a story on you. That's just beautiful work.
We launch on June 17th, the Cut for Health initiative. I'm sending invitations to everybody.
Well, thank you so much. Really appreciate you being on. Bye.